Okay, we're going to continue on with our discussion of the abdominal organs. So we last talked about the small intestine, and now we'll continue with the large intestine. In general, you can see the large intestine beginning right here at the cecum, extending up the right side of the abdomen, crossing across the abdomen towards the left, coming down the left side of the abdomen, and then going through the sigmoid colon and into the rectum. When we look at the parts of the large intestine, this includes the appendix, which is this tiny finger-like appendage hanging down from the very beginning of the large intestine, the cecum, which is this first pouch of the large intestine that accepts contents from the ileum, the last part of the small intestine, the colon, which can be broken up into an ascending, transverse, descending, and sigmoid colon. The rectum, which is this last like 5 inches or so of the large intestine. And then finally the anal canal, which is the canal that leads out of the large intestine and really out of the entire alimentary canal. When we look at the large intestine, compared to the small intestine, there are a few physical differences in them. First off is diameter. The reason the large intestine is called large is because it has a much greater diameter than the small intestine. The small intestine is about 1 inch in diameter. The large intestine is about 2.5 inches in diameter. So it's a lot shorter. The large intestine is a lot shorter than the small intestine. But large versus small is just talking about the diameter, the size of the tube, or thickness of the tube. When we look at the large intestine, the longitudinal muscle, right, the layer of longitudinal muscle that lines the intestine is like decreased into just 3 bands of muscle. We refer to them as tenia coli. So throughout most of the GI tract, remember there are 2 layers of muscle. So throughout like all of the small intestine, there's a layer of circular muscle that goes around the tube, and then there's a layer of longitudinal muscle that goes along the length of the tube. When we get to the large intestine, there's circular muscle everywhere, but there's not a complete layer of longitudinal muscle. There's just 3 strings, right? 3 bands of longitudinal muscle. We refer to those as the tenia coli. They extend from the base of the appendix, which is towards the beginning of the large intestine, all the way to the rectosigmoid junction. So at the rectosigmoid junction, that's the junction between the sigmoid colon and the rectum, those tenia coli become a complete layer of longitudinal muscle again. So the rectum itself has a complete longitudinal layer of muscle. Okay? It's no longer the tenia coli anymore. Now the tenia coli themselves, these 3 bands of muscle, are shorter than the actual length of the large intestine. So what that means is that the length of the large intestine gets pulled, right? It gets scrunched in to meet up with the length of these tenia coli. Because of that, picture like a drawstring, right? When you have a drawstring in your pants, when you pull the drawstring tighter, it makes your pants like cinch up, right? Makes them like scrunch up. That's what happens with the large intestine. That's why when you look at the large intestine, it's not flat, right? It's not like a flat tube like this. No, it's in these little sacculations, right? It gets pulled into these little saccules. We call those haustra. So because the tenia coli are shorter than the entire length of the large intestine, it gets pulled short like this, which creates these little haustra. So each of the little like pouches that you see, those are haustra. When you look at this bottom picture right here, you can see the 3 bands of tenia coli, right? So like this band, and then there's one here and one here. So like kind of forming like a triangle around the outside of the large intestine. All right, so we'll go through all of the different parts of the large intestine from the beginning to the end. And we'll begin we'll begin with the cecum. Again, the cecum is this first pouch of the large intestine. So this literal first pouch right here where the ileum empties into the large intestine. So the first part of the large intestine, it's located in the lower right quadrant of the abdomen. The cecum is a blind pouch, meaning it's not like a connecting tube, it's a blind pouch. It ends, like if you look at the end of it, right, there's like a dead end that's located down in the iliac fossa, specifically the right iliac fossa, which is the little like indent, the little like curved area made by the right ilium, the hip bone. You can see that in the picture right here. This is showing you the right side of the pelvis, and the iliac crest is the top of your hip bone right here. So sitting in this iliac fossa, you see the cecum. The cecum is continuous with the colon. So after the cecum, it opens right up into the ascending colon that goes up the right side of the abdomen. The ileum, which remember is the last part of the small intestine over here, the ileum enters the superomedial wall of the cecum at an oblique angle. So if you look at like the top and kind of like medial back aspect of the cecum, here if you look at the bottom picture, you can see the ileum comes up the back, like kind of behind or the medial aspect of the cecum, and enters in through that wall. And you can see it kind of poking through right there. Where the ileum enters into the cecum, it's not like the ileum just ends flat at the cecum like this. The ileum actually like invaginates, it pushes in to the cecum. So it invaginates partially, like pushes through the wall of the cecum, forming the ileal orifice and ileocecal valve. The ileal orifice is the actual opening from the ileum. So where the contents go from the ileum into the cecum is through the ileal orifice. This picture on the bottom, the pen is pointing to that ileal orifice, the opening. Now the muscle that surrounds it, like the wall of the ileum that's invaginating into the cecum, because of the way that this pushes in, it creates a one-way valve, referred to as the ileocecal valve. Ileocecal because it's going from the ileum to the cecum. And like most valves, it's a one-way valve. It allows things to flow from the ileum into the cecum, but the things can't go backwards. So the ileocecal valve prevents backflow from cecum to ileum. And this is really important because think of the way we break things down in the large intestine. In the large intestine, we have colonic bacteria. There are a lot of colonic bacteria that are naturally in the large intestine. They're supposed to be in the large intestine, but these bacteria are not supposed to be anywhere else. They should not be making their way into the small intestine because then they can cause infection there. So it's important that this ileocecal valve works as a functioning one-way valve. Hanging from the cecum, we have the vermiform appendix, or what we would generally just call the appendix. Vermiform means worm-like, and if you've ever seen an appendix, it actually does look like a little worm, like a kind of pinky-sized worm that hangs down from the cecum. If you look at this first picture down here, remember the cecum is this first pouch of the large intestine, and then you can see this little structure right here hanging down off of it. That is the vermiform appendix. So the appendix is a blind intestinal diverticulum. Remember, a diverticulum is just a pouch, like a little outcropping or pouch. So there's a blind, meaning a dead end, it dead ends, intestinal pouch that extends from the posteromedial wall of the cecum. So this hangs down from the cecum just inferior to the ileocecal junction in the lower right quadrant of the abdomen. When we look at the vermiform appendix, the appendix usually lies retrocecal, so it sits just partially covered behind the cecum, and the base of the appendix is just deep to a point that we call McBurney's point. McBurney's point, you can see illustrated in this picture. This little red dot is showing you McBurney's point. It is about 1/3 of the way in on the oblique line from the right anterior superior iliac spine to the umbilicus. The anterior superior iliac spine can be found at the very front of the iliac crest. So you can see here this curve up here at the top of your hips, which you can easily palpate the curve of the hip. That's the iliac crest. If you follow, so go and palpate your iliac crest. If you follow the iliac crest around towards, like anteriorly towards the front, you'll feel a little hook at the very front of it. That's the anterior superior iliac spine. So around the front of this, like right here, is the anterior superior iliac spine. If you draw a line from there to the umbilicus, which is just the belly button, and go about 1/3 of the way in from that, that's McBurney's point. McBurney's point is important because this is where pain is felt the strongest when appendicitis is present. That's where the base of the appendix is. So that's where patients will usually describe pain, especially if pressure is applied to McBurney's point. We'll talk about that more when we talk about appendicitis in a minute. In this picture here, on the top, you can see the actual surface anatomy, the actual physical landmarks to find McBurney's point, which again is where the base of the appendix is. Here you can see on the side, here's where the iliac crest is, right, the hip bones. If you follow that to the front, you'll feel a little hook at the very front of the iliac crest. That's the anterior superior iliac spine. And we're going on the right side. If you draw a line from there to the umbilicus, and we're going about 1/3 of the way in on that line, that's McBurney's point. Here you guys can see arterial supply and venous drainage going to the cecum and the appendix. Arterial supply originates at the superior mesenteric artery. SMA is the superior mesenteric artery, which remember is like the second big branch off of the abdominal aorta. So you go celiac trunk, and then underneath that we'll see the superior mesenteric artery. So the superior mesenteric artery is coming down right here, and then it has numerous colic branches that are going to different parts of the colon. The ileocolic artery is this branch right here that goes down. Let me change color, sorry. So you see the superior mesenteric artery here, and then you see the branches that go to the different parts of the colon. Ileocolic artery is this branch right here. It has branches that go to the ileum and to the initial parts of the large intestine. So the ileocolic artery is going to end up giving us blood to the cecum. The appendicular artery is this tiny little like branch that comes down to go to the appendix. Venous drainage is the same, just backwards. So the appendicular vein drains from the appendix. That goes into the ileocolic vein, which is going to be accepting blood from the cecum as well as the ileum and the appendix, and that drains into the superior mesenteric vein. Remember, the superior mesenteric vein comes up here, right in this area right here behind the, like right back behind the stomach and pancreas is where the splenic vein will meet the superior mesenteric vein, and that forms our hepatic portal vein. So here you guys can see the different lymph nodes that are present. There are a lot of lymph nodes surrounding the intestines, just because this is a really great area for, antigen, bacterial, viral entry. The lymph, however, just follows the vessels. As we usually see, the lymph nodes are named for the vessels that they're around. So lymph is just going to follow the same path. We had appendicular nodes around the appendix. Appendicular nodes are going to then drain into the ileocolic nodes. So right here you see ileocolic nodes. Ileocolic nodes are going to drain into the superior mesenteric nodes. And then we continue to go up from there. All right, so continuing on, remember we're talking about the large intestine, and we said the large intestine begins at the cecum, which is tucked back, like kind of posteriorly. It's tucked back over here towards the back of the body a little bit though, right in that right iliac fossa. After the cecum, we go up into the colon, which we said the colon was broken up into 4 parts. The first part is the ascending colon. The ascending colon rises on the right side of the abdomen from the cecum all the way up to the right lobe of the liver. It's located further back in the abdomen, so it's kind of difficult to see where it is here in this cadaver, but it's coming up the right side of the abdomen right here. Again, it kind of gets partially covered by the small intestine because it is located a little bit more posteriorly than the transverse colon is, which we'll see in a second. Now, the ascending colon flexes forward and medially at the right colic flexure. So it's going to turn forward and towards the left at the right colic flexure. The right colic flexure is also the hepatic flexure. So it ascends up until you get to the liver, which if you look at this picture, this up here is the liver. You can see the gallbladder in green underneath. So the colon goes up, flexes anteriorly and medially or left, and then it'll become the transverse colon, which the transverse colon is colored blue on this cadaver image. When we look at the position of the ascending colon, I told you guys the ascending colon is located further back. It is located retroperitoneal, so it's located back behind the peritoneum. The peritoneum covers the anterior and lateral aspects of the ascending colon. Okay, so it is not located inside the peritoneal cavity or inside the peritoneum. It is separated from the anterior abdominal wall by the greater omentum. The greater omentum, remember, is the omentum that extends down from the greater curvature of the stomach, right? And it comes down and it hangs like a bib over the top of this. And that kind of fatty layer will separate the ascending colon from the actual anterior abdominal wall where the muscles and fascia are. There is a short mesentery, like membrane, that extends from the ascending colon in about 1/4 of people. So it's not present in everyone, but it is relatively common to have a short mesentery that extends from the ascending colon. Okay, continuing on with the colon, after the ascending colon, we get to the hepatic flexure flexes across, and the ascending colon becomes the transverse colon. The transverse colon goes horizontally across the abdomen from the right colic flexure to the left colic flexure. The right colic flexure we also said was called the hepatic flexure, right? It occurs at the liver. The left colic flexure is also called the splenic flexure. So the transverse colon goes horizontally across the abdomen, and then it flexes back posteriorly and downward to descend along the left side of the abdomen. The left colic flexure, the splenic flexure, is higher than the right. What that means is like the ascending the ascending colon goes up, and then it flexes to the transverse colon, and the transverse colon goes up like this, and then flexes down to be the descending colon. So the splenic is higher up than the hepatic. And this makes sense if you think about like the organs that are over there. The right lobe of the liver is just so big, it takes up a lot of space. So the right flexure is lower, and we can kind of traipse up as we move towards the left. The left colic flexure sits just anterior to the very bottom of the left kidney. Again, we're flexing posteriorly because the ascending and descending colon are going down like the posterior abdomen. The transverse colon is attached to the diaphragm by the phrenicocholic ligament. Phrenic, remember, always refers to the diaphragm. So phrenicocholic, diaphragm to colon. And the phrenicocholic ligament provides some like suspension to the transverse ligament. At the left colic flexure, the transverse colon flexes downward or bends downward and becomes the descending colon. There is a mesentery, a supportive membrane that connects to the transverse colon. It's called the transverse mesocolon. This is the mesentery of the transverse colon. The root lies along the inferior border of the pancreas, and it extends down and attaches to the transverse colon. And the mesocolon is continuous with the parietal peritoneum posteriorly. This area here, like this left colic flexure, this splenic flexure, represents another one of our transition points when we talk about blood supply. Up into this point, like the other parts of the colon are supplied by the superior mesenteric artery. At this splenic flexure, right, or this left colic flexure, now the parts distal to this are going to be supplied by the inferior mesenteric artery. And just because, like, embryonically speaking, when we're talking about the development of the gut, the beginning parts here that are supplied by the superior mesenteric artery, that's the midgut developing. And then after this, the parts that are supplied by the inferior mesenteric artery, that's the development of the hindgut. So that's why they have like the different arterial supplies. But just realize this is a transition point in blood supply where we go from the superior mesenteric artery to the inferior mesenteric artery. And that is important if you're talking about, blood supply or clamping arteries and understanding what you're going to be cutting off blood flow to, or if there's a bleed or a clot and you're worried about, what's getting blood flow and what's not, you should know that this is a transition point in blood supply. Okay, so here in this picture, highlighted in blue, this is showing you the transverse colon. You can see it extending from the right colic flexure, right underneath the liver, up to the left colic flexure, which is right below the spleen. You can see that the left is higher, right? So it kind of ascends as it crosses. As it crosses. If you look at this other picture right here, this kind of fatty layer right here, this is the greater omentum. right? So like the stomach is pulled up, but the stomach would hang down right here, and coming from the greater curvature is the greater omentum. We've cut that greater omentum away and pulled the stomach away so that you can see behind it. This is showing you the transverse mesocolon, right, which is the supporting membrane that goes from the transverse colon, and then its root lies up here at the pancreas. This point right here, this would be the transition in blood supply. So the superior mesenteric artery comes down and around to the cecum, ascending and transverse colon. At the end of the transverse colon, where we flex down to the descending colon, now that's all going to be fed by the inferior mesenteric artery. Continuing on with our colon, at the splenic flexure, or the left colic flexure, our transverse colon flexes posteriorly and inferiorly and becomes the descending colon. The descending colon descends on the left side of the abdomen from the left colic flexure all the way down the posterior abdomen into the left iliac fossa, which remember is just a little curvature inside the ilium of the pelvis, or inside like the left hip. The descending colon is then continuous with the sigmoid colon, which we'll talk about next. The descending colon, much like the ascending was, is retroperitoneal. So it is behind the peritoneum. It's located just inside the posterior abdominal wall. The peritoneum covers the anterior and lateral aspects. So it literally sits just behind the peritoneum, and the peritoneum is kind of sitting over the top of it, but it's not inside the peritoneum. There's not a normal descending colon mesentery, but it is present in about a third of people. So kind of like with the ascending colon, we said there was a short mesentery in about a quarter of people. About 33% of people have a short mesentery at the distal end of the descending colon. So at like the very bottom of the descending colon, there'll be a little short mesentery that extends off the descending colon that provides support for that part of the colon. After the descending colon, we go into the sigmoid colon. The sigmoid colon is the relatively like S-shaped, sorry, it comes down like that. The relatively S-shaped last part of the colon that provides a connection between the descending colon and the rectum. It extends from the left iliac fossa laterally inside the left hip in towards the center of the body to the third sacral segment. So the third segment on the sacrum, which remember is a fusion of 5 bones, so like the middle of the sacrum. The sigmoid mesocolon is the mesentery of the sigmoid colon. So there is a normal mesentery that extends off the sigmoid colon. It's the sigmoid mesocolon. So here, looking in this picture on the right, you can see the sigmoid mesocolon, right? So this mesentery right here that connects and supports the sigmoid colon is the sigmoid mesocolon. Looking at this picture, the first picture here, you can see the general shape of the sigmoid colon. The descending colon came into the sigmoid, which is this relatively S-shaped colon that would then empty into the rectum. And then again, yeah, the sigmoid mesentery. Here you guys can see the blood supply going to the colon in general. Remember, this is coming from both the superior mesenteric artery and the inferior mesenteric artery. You can see the superior mesenteric artery coming down from the abdominal aorta and then down. we have our ileocolic artery, which we already looked at, that comes down to the ileum and the cecum and the appendix. And then after that, we have our other colic branches that extend out to the ascending colon and the transverse colon. You have your your right colic artery, your middle colic artery. You have those are, and then like your straight arteries are the little tiny ones that actually go to the colon. But you just need to know the big branches. And then remember right here, that's our transition point, and the other branches are coming from the inferior mesenteric artery. So down here, coming off of lower down on the abdominal aorta is the inferior mesenteric artery, and you have your left colic artery. You have your sigmoid artery, so like sigmoids coming down to the sigmoid colon, sigmoid arteries. And again, little straight arteries are like the tiny little ones that actually go to the colon. This is just showing you venous drainage that comes from like in the opposite direction from the intestines. Remember, venous drainage from the GI tract goes through hepatic portal circulation. So just like we saw coming from the cecum and appendix, it's really the same as the arteries, just the opposite direction. Instead of arteries going to it, we've got veins leaving from it. But we still have our same branches coming from the colon and going into the superior mesenteric vein, and then the same transition point in blood supply, where we have our vessels coming from the descending and sigmoid colon, right? We have our sigmoid veins, we have the left colic vein, and these are going into the inferior mesenteric vein. Remember, the inferior mesenteric vein merges with the splenic vein, right? And then the superior mesenteric vein merges with the splenic vein, and that becomes the hepatic portal vein. Okay, so we'll talk about appendicitis. Okay, so appendicitis, you guys know itis is inflammation, so appendicitis is inflammation of the appendix. This is relatively common, and the reason that this occurs is, remember, the appendix is a little blind pouch off of the cecum. Functioning wise, this is a little mass of lymphoid tissue. We used to always say that there was no reason for this, we don't need it. There is more recent research that's saying there is a beneficial function to the appendix, that this mass of lymphoid tissue does include important like microbiome. However, you can live just fine without it. We do pretty frequently remove them, and we don't see like long-term issues with patients. We don't have any differences in like rates of vaccines or like any additional vaccines needed or anything like that, like we do in patients post-splenectomy. So while we are learning more about the appendix and its possible function, you still, can live just fine without your appendix. So appendicitis is, again, when there's inflammation of the appendix. The appendix is a little blind pouch off of the cecum. The reason that appendicitis usually happens is it begins with some sort of obstruction in the appendix. So something gets down in there and obstructs it. Because of that, there's an increase in pressure present. It needs to be able to drain into the cecum. If it can't, there's an increase in pressure, and that causes a breakdown in the mucosa. When there's a breakdown in the mucosa, then all of the bacteria that are naturally in that area can invade deeper within the wall, and that causes more intense infection and inflammation. So appendicitis is associated with infection. This is an infective process, which is why we see fever. Appendicitis is a very common cause of acute abdomen. Acute abdomen is when there is sudden, severe abdominal pain. Again, this is a common cause of acute abdomen. In addition to this really sudden, severe abdominal pain, patients frequently also have fever, again, because this is infective. We'll very frequently see nausea, vomiting, and diarrhea associated with it as well. This is an issue with the GI tract, after all. Patients will exhibit guarding of the abdomen, meaning it's just a natural reflexive reaction to try and guard their abdomen when you put pressure on it. So like when you put pressure, when you push on McBurney's point, that's where there's digital pressure over McBurney's point produces maximum tenderness. Remember McBurney's point, that 1/3 of the way from the anterior superior iliac spine to the umbilicus on the right side. That's where the McBurney's point is directly over where the base of the appendix is. So when you put digital pressure there, when you push there, you're increasing the pressure on an area that already has too much pressure, that has pain. So that produces maximum tenderness and pain. Patients will usually just naturally, without thinking about it, guard when you try and do that. So what that means is when you try and push on that area, they tighten up their abdomen. They flex their abdominal muscles, right, and kind of curl up to try and prevent you from putting that pressure on. That's what guarding is. We ask patients, like, there's such pain in the abdomen that jarring of the abdomen hurts. So like if you ask a patient to stand up and hop, they won't stand up and hop because of the pain that it induces. The pain from appendicitis frequently begins as a vague pain in the periumbilical region. The reason that there's periumbilical pain is because the afferent fibers, so like the pain fibers that are leaving the appendix, enter the spinal cord at the T10 level, which is the same for the periumbilical region. So that's referred pain. There's referred pain to the periumbilical area. Later, it results in severe pain in the lower right quadrant due to irritation of the peritoneum in that area. And again, that's the McBurney's point area where the pain is. So the way that we treat appendicitis, appendicitis can be treated if you catch appendicitis very early, may be able to be treated with antibiotics. We frequently have to actually remove the appendix. So if this is uncomplicated appendicitis, meaning there's no rupture, you've caught it early, there's no rupture, you can just use antibiotics. For example, Pip-Tazo. Pip-Tazo is a combination of piperacillin and tazobactam that can be used for appendicitis. However, if there's any, if it has ruptured, or if you fear that it's so far along that it is close to rupture and you don't think the antibiotics will work in time before it will rupture, then you can do an appendectomy. Right? So an appendectomy can be done laparoscopically. Laparoscopically meaning with you make tiny little incisions, and tools, your instruments are put through the incision, so you don't have to actually open up the abdominal cavity with like a larger incision. So laparoscopic appendectomy is a standard procedure to remove the appendix through these 2 to 3 small incisions. The peritoneal cavity is distended with CO2, so we use gas to distend the abdomen so that you can easier see and access the appendix. The laparoscope, which allows you to visualize, is inserted through an incision in the anterolateral abdominal wall, either through the umbilicus, so like right through the belly button or near the umbilicus, And then again, there's 1 or 2 other incisions that are made for instruments so that you can access the appendix and vessels and clamp, stitch, clip, and remove as necessary. An appendectomy can also be performed through a transverse incision that's centered at McBurney's point in the lower right quadrant. So you can, instead of doing this laparoscopically with a camera and tools inserted through little incisions, you can make a small little transverse horizontal incision at McBurney's point and access that way. That's like the old way we used to do it. However, doing it laparoscopically through the little portals tends to heal better and cause less distress to the tissue.